There's a big problem that's draining over $1.5 billion from the Australian healthcare system annually: unplanned readmissions. It's a problem that's plagued the healthcare system prior to the pandemic, and now in 2023, we're at a tipping point. How do we turn unplanned readmissions from a regular occurrence into a rare event? Can the adoption of digital health be the solution? With me today on the show is Ken Saman, CEO and founder of Personify Care. And in this episode, we talk about the role of patient adoption in dramatically reducing clinical risks and unplanned readmissions, how data and machine learning are transforming healthcare, and how patients using more digital health solutions will reduce clinical risks and improve outcomes. Collaboration starts with a conversation. Team HealthTech, let's make it happen. This is Talking HealthTech with me, Peter Birch, featuring content and community about technology in healthcare.
Hey Ken, how you going?
Hey Pete, good to have you.
Good to be here in Adelaide with you and chatting about all things Personify Care. It's been a while since we've last spoken on the podcast. I assume you've been up to a little bit.
Yeah, lots going on. Doing a lot of work across different states in the country, particularly in public health around outpatient wait lists, surgical wait lists, and virtual care more generally. Doing some work internationally now in New Zealand and further afield, and starting to work with a whole bunch of partners as well, which is pretty exciting. So lots going on.
Yeah, interesting. And tell me a little bit more about working with partners, and maybe in the context of those that don't know Personify Care. We could go back and listen to some previous episodes, but I'm interested to learn a bit more about how that ties in with the partners as well.
Yeah, absolutely. So, at a basic level, what we've been doing over the last several years is really helping health services convert their clinical models of care into digital patient pathways, which we've proven over that time is that we can improve access to patients, but significantly reduce the administrative burden on clinical staff. And so we have a lot of data around that now that proves out that case. And so where we're turning our attention next is, now that we've proven we can improve efficiency, how do we now partner with other organizations that have developed evidence-based models of care, education modules, clinically validated tools, to then start to provide those as libraries of pathways to our health service customers. Because traditionally there's been a lot of friction between the research world and all the evidence and health services in practice actually adopting those models of care. And largely that's been because, one, it takes a lot of effort to change your workflow, and to deliver those models of care often requires a lot of resources, people, time and capacity, which health services don't have these days. And so by starting to provide these libraries of evidence-based pathways, as we're calling them, we're trying to reduce that friction of health services adopting the models of care. And so we're just at the beginning of that journey now.
Yeah. And so you mentioned there's this challenge of a lot to do and not enough people to do it. And a lot of people at the moment are very excited about when we go down that path of speaking about efficiencies and the role of technology. Often that conversation leads to artificial intelligence and the role of AI and ML in healthcare. I'd love to know your thoughts in terms of how AI plays a part in particularly what you're doing with Personify Care.
Yeah, absolutely. So look, I think there's been a lot of discussion in this space recently, as everyone would know, around how AI and machine learning and all the latest advances in that space can help start to predict things in healthcare. So predict clinical risk for patients, predict the risk of readmission, predict demand on health services. And I think that's really exciting from our perspective. I guess we're taking a little bit of a different tack in that one of the more fundamental problems I think health services have is the lack of data quality they have within their organizations about their patient populations. And, at a basic level, if you apply machine learning and AI to poor quality data, your quality of your predictions are probably going to be pretty low quality as well. So we've really looked at how do we use data to actually reduce the friction for patients at scale, and in the process improve efficiency for health services. So if we take an analogy, every morning I drive into work, I use Google Maps to find the shortest path. And so about 10, 11 million Australians use Google Maps to do that every day. And every time one of us does that, it improves the prediction accuracy and improves the experience for the next driver, right? We're trying to do a similar thing for patients, right? So we've got this platform that clinicians are developing all of these different digital pathways on their journey into an outpatient appointment or into a surgical admission or post-discharge that are being controlled by those clinical teams and are being adjusted against clinical guidelines. And so where we've started to apply machine learning and data-driven algorithms is how do we actually reduce the friction for different cohorts of patients, improve response rates to those pathways as they're being updated for different clinical settings. Our thesis is if we improve the experience for the patient and make it easier for them to interact and respond to these pathways, one, will be able to even further improve efficiency for health services, but also do important things from a clinical perspective around improving visibility to clinical risks and prevent bad things from happening from a clinical perspective, or even just basic things around improving utilization of theatres and appointment slots by making sure we reduce cancellation rates, etc.
Yeah. Well, I'll come back to the use of AI in a minute, but just to double click on the problem a little bit further there, I know we've spoken in the past about, and I think our conversations were all around, either it's just coming off the back of the peak of the pandemic and wait lists for surgeries and things, and you were kind of concerned about what things might look like now and into the future. So we're kind of in the thick of it now. There's a big problem to solve.
Yeah, there is. And across Australia and even internationally, I think post-COVID, there's been a big lag in terms of the ability of the health system to start to catch up on those planned surgical procedures that were put on hold during COVID. So I think the latest estimates from the AMA suggested that there are about 500,000 Australians currently waiting for surgery at the moment.
Wow.
And then there are even... the precursor to that is going to see your specialist to see if you need surgery. So there's even longer waiting lists to actually access that specialist appointment in an outpatient setting. So there's all this hidden demand, I guess, in the community. And the cost of that isn't just pressure on the health system, as everyone would know, the longer you wait for your surgery, the longer you wait for access to healthcare, the more likely that you are going to deteriorate and your risk profile gets worse. So there's a lot of pressure on health systems to try and address that, but at the same time, there's a big workforce shortage in Australia and a number of other countries, both from a clinical and nursing perspective. And so there's a whole range of different policies and initiatives around how do we fill that gap, both from a build more hospital beds through to training more nurses and clinicians. But all of those things are going to take years to flow through into the system. And there's a lot of competition from different parts of our health system and different countries for those people in that capacity. So, my view is if we keep doing more of the same, we're never really going to catch up and we're going to either run out of money to do all of this stuff or just not provide healthcare to the patients that actually need it.
And as you were saying that too, in terms of the broader impact on the healthcare system, because that means that people will deteriorate further and require further health interventions. Think about the bigger picture and the macro kind of economic picture. Healthy humans are then consuming goods, thriving ecosystem, stuff like that. So it's at the heart of this problem is this really, really tricky one. But as you say, it'd be great if we could just chuck more people at it or resources at it to solve it. We don't have that. So, enter this the use of artificial intelligence a little bit more. That really interesting concept that you brought up about, did you say drive more patient engagement? Because that's interesting that typically, and even I do this often, speaking about AI in healthcare, you can either use AI to be for diagnostic purposes, to assist with the diagnostic side and reviewing images or whatever it might be, or it could be on the back end side in terms of doing all the boring stuff that humans are okay at but machines are better at in terms of financials and making sure things get billed correctly. But then you're talking about engaging with patients utilizing AI. Tell me a little bit more about that.
Step one is we recognize fairly early on that every clinical team is different. Every hospital is different. Even within a particular health service, different parts of the organization will have different workflows and different clinical guidelines around how to look after their patients. And so whilst, in the early days, there were a whole bunch of one-size-fits-all applications, that wasn't going to solve the problem at scale for health services, because you can't just apply technology to a health service and expect the workflow to adapt around that. So we started with clinicians being in control of their clinical pathways, if you like, and being able to map their existing workflow really quickly into a digital patient experience. So the next challenge is, well, that's good in theory, but if patients don't actually respond to these pathways, you're back to a whole bunch of labor-intensive manual work of how do we prepare patients for their appointment, how do we prepare them for their surgery, how do we make sure they're recovering well after a procedure. Given that we now have a significant amount of data flowing through our platform, how could we use some of these advances in this space to reduce the friction for the patient, improve their response rate, and in the process, automate away 80% odd of the manual work involved in preparing patients and managing the recovery. So to give you some idea of scale, in the last 3 years or so, we've had just over 24 million patient interactions go through the platform across all sorts of different pathways, across most specialties, and all of these pathways are changing all the time based on what clinicians are adjusting in their own pathways. So then we looked at data in three different dimensions, if you like. On the one hand, we know a whole bunch of stuff about the patients, their demographics, when they're accessing their pathways, what devices they're using to access their pathways, time of day they're interacting, etc. What specialty they're having, what procedure they're having, what part of the patient journey. We then have a whole bunch of attributes around the pathway itself and the workflow that clinicians are using. So how many different steps are there in the journey? What type of interactions are clinicians asking their patients to go through to, what's the gap between one interaction and the other, etc. And then we have a third dimension, which is what's the user interface actually look like in front of the patient? What are the colors on the screen? What are the words on the screen, etc.? And what we started to do is say, well, we can actually vary all those three things simultaneously and provide a really personalized experience for an individual patient so that it's not a one-size-fits-all experience through that. So to give you an example, one of the early things we learned when we first started was the time of day you notify certain age groups might have a big impact on their response rate to a particular intervention. So it might be better to, and I'm just making these numbers up now, but it might be better to notify a 30-year-old female at 3 o'clock in the afternoon versus a 60-year-old male at 10 o'clock in the morning, right? So we let the data... Don't
notify me at 3 p.m. That's school pickup time,
exactly.
by the way.
Yeah, exactly right. Yeah.
You said 3 p.m. It's like, no, it's not happening.
Exactly. And then you can vary all those things. You can vary what it looks like on the screen to different cohorts of patients based on your cultural background or the language that you're using or based on just what device you're using, etc. And which means that each person within a particular pathway, in a particular hospital, in a particular surgery can have literally a different experience. And in doing so, we can reduce the friction for that patient and increase the chance that they're going to respond to that pathway over time. And then we can use data about how patients are responding to that pathway to then drive additional improvements to that pathway's response rate. So what does that mean? And so what, right? That means that now we're seeing in the last 12 months, we've averaged across all of the interactions we've had in the last 12 months, sitting at a response rate of over 90%. So 90% of everything a clinician's been asked the patients to respond to, they've responded to. And in doing so, we've improved the experience for the patient. But the real benefit from a health service perspective is, one, we're allowing clinicians, nursing staff, and healthcare professionals focus their time on the few patients that need some actual support rather than spending their time exchanging their information manually. But two, detect issues early so we avoid surprises. And a surprise could be complications, bad outcomes clinically, or it could be I've cancelled the procedure and now we've wasted a theatre slot for those 500,000 Australians waiting for surgery, right?
And I would imagine too, that those outcomes, or like if you extrapolate that further in terms of the benefits, and I think it's wonderful that patients have, receive better care and feel better about the system, but to quantify that sometimes can be harder, or maybe not as even convincing when you look at the kind of bigger picture in terms of the impact. But surely this then flows on to clinical outcomes and, the measurable stuff that we're really trying to pull the lever on. If patients got greater adoption through the process, the outcomes have got to be better.
So in terms of, what's the flow-on benefits of these things, we've measured a whole bunch of these things across a whole range of different clinical settings. So, at a basic level, yes, the patient experience is better, unsurprisingly. But we've actually tested, just the understanding of patients of their clinical instructions, their health literacy, as it's called, right? So patients, by going through this process, are much more likely to recall, understand, and act on the information they've been provided with, because now you're provided with a bit of information that's relevant to you rather than the one-size-fits-all packet of information. That means you arrive for your appointment or your procedure better prepared clinically and administratively, so there's less likelihood there's going to be a cancelled appointment or procedure. So in outpatient settings, we've got examples where we've reduced the no-show rates in outpatient settings by of the order of 40-50%.
Sure.
In surgical procedures, examples where we've reduced day of surgery cancellations by 20-30%. And again, that the flow-on effect of those patients that are waiting for surgery having access to that theatre slot because someone's not prepared is significant from a number of perspectives. But then in terms of the clinical benefits, I think, you were talking before about as patients wait longer for their care, their complexity increases. That combined with the fact that we've got an aging population means that every year the complexity of patients going to hospital is getting higher. And some of the evidence we've looked at from the research world say that, we're still seeing 1 in 5 patients get readmitted post a surgical procedure within a 4-week period after going to hospital. So that's
1 in 5.
20% of patients going to hospital being readmitted. Now, if we can detect some of these risks post-discharge early and prevent a complication or readmission, obviously good for the patient, but also helps solve some of that demand problem.
Yeah.
And that's really where we're headed next, right? So we've proven that we can drive efficiency and visibility to risk. So the next phase for us is that piece around partnership. So can we start to then take models of care that, based on the evidence, have been proven to improve outcomes for patients, so reduce readmissions, reduce complication rates, improve health outcomes, but actually provide them to health services in a way that they can deliver them at scale, so that we can actually see these models of care actually be adopted in the real world and magnify the outcomes by delivering them to more patients, right? And that's kind of where we're headed next, is to, rather than pretend we're a clinical intervention, right, we're the effectively platform to deliver some of these clinical interventions at scale.
Interesting. And I imagine too, it's not just a problem that we face in Australia, it's one that would impact health systems globally.
Yeah, look, I think it's definitely not just an Australian problem. I think it's very true of a whole range of different developed economies. I think where there are aging populations, COVID put a hold on surgeries. It's a global problem for sure. So we're starting to do a lot of work in New Zealand. We're starting through some of our partnerships explore markets like the UK, UAE, Canada, North America more generally. So lots of opportunities to kind of apply some of these same principles to the global problem for sure.
Amazing. Well, Ken, look, we'll put the details for Personify Care in the show notes of this episode. Got a good presence on the Talking HealthTech website as well. So whether it be those technology partners looking to perhaps do some grander things at scale with you, or some healthcare settings that have these problems to solve around the wait times and delivering care in an effective, more sustainable way, they can get in touch. So, Ken, thank you so much for making the time.
Thanks, Pete. Appreciate it.
For more content and community about technology and healthcare, visit talkinghealthtech.com.